huge thank you to all of us for joining. It's great to see we've got a good number of participants joining today's webinar. So for anyone who isn't familiar with who I am, my name's Alice. I work in our support services team alongside my colleagues Anna and Annie. A quick introduction to the support service, just as a reminder of what we offer to you. We have a support phone line. You can drop us an email. We have an instant chat service on our website. You can even send us a text if you like to talk that way. And we're really happy to schedule a one-to-one Zoom meeting with you as well. So you can feel free to get in touch with the support service with any particular questions that we may be able to help you with. Any information that you're looking for, we might be able to point you in the right direction. Or even just for a general chat. If there's anything at all that you'd like to talk through, we are here for that as well. So we're on hand from Monday to Friday from 10 a.m. to 5 p.m. So I would like then to really warmly introduce our speaker for today. So we're very, very happy to be joined by Dr. Terri McVeigh, who is a consultant oncogeneticist at the Royal Marsden. She's also a member of our expert advisory panel, so we are extremely grateful to benefit from her expertise in that way as well. So thank you, Terri, for joining us today, and I will pass over to you.
Amazing. Thank you so much, Alice. Just bear with me now till I see if I'm sharing the right thing. Cool. Can you see that okay?
We can, yeah.
Amazing. Brilliant. So thanks very much. It's always a pleasure to come and speak for Overcome, because you do such amazing work, and you're a fantastic organisation. So thank you for inviting me. And today I'm going to speak about the rarer causes of hereditary ovarian cancer, because I think things like BRCA1 and BRCA2, the BRCA genes, get a lot of attention, and rightfully so, because they do account for the bigger chunk of the rare causes of ovarian cancer heritability. But there are others that we also need to consider as well. So we thought they deserved a little bit of attention. So we're going to go through some of them today. So the outline of the talk, we're going to just briefly, do an overview of the genetic risk factors and genetic drivers that might occur spontaneously as well in ovarian cancer. We're going to talk a little bit about the risks that are associated with some of these heritable risk factors for ovarian cancer. We're going to describe what people who carry these genetic risk factors can do to try and manage their risk, ideally before cancer develops. And we'll go through some of the NHS guidelines for genetic testing, because I know that always kind of confuses people as to what they're entitled to and what they're not entitled to through the NHS services. So, this audience probably doesn't need to be told this, but this is just a picture of the female gynae tract. And it's amazing how many, maybe it's not that amazing actually, but it still sort of surprises me how often women come in and actually have no clue what bits are where. So essentially our ovaries are these little structures that sit really deep in our pelvis. These are the fallopian tubes that connect to the womb there. Then you have the cervix, and then you have the vagina leading out to the vulva. And we talk about cancer of the ovary, but actually what we should probably really be referring to is tubo-ovarian cancer, because actually, particularly for some of the subtypes of ovarian cancer, the thinking is that actually the dodgy cells probably start off in the fallopian tube and make their way out to the ovary. So it probably is more accurate to say it's fallopian tube cancer than ovarian cancer, but we call it all under the umbrella of ovarian cancer, and it's all treated very much the same way. There's also a related cancer of the inner lining of the abdomen, which is called the peritoneum, and some people get primary peritoneal cancer, which is also sort of considered under the same bracket, and also can share some genetic risk factors as well. So how common is ovarian cancer? Again, a lot of the audience here will know this, but about 1 in 70 people with ovaries will develop ovarian cancer in their lifetime. So, just over 1%, between 1 and 2%. But certain people have a higher risk than that. And the risk factors that we know about, certainly increasing age, like ovarian cancer is not typically a cancer of younger people. So we know the older you get, the higher the risk. There are certain reproductive risk factors as well. So we know that women like myself who don't have children are at higher risk. We know that there are certain factors that are protective. So being on the oral contraceptive pill for a long time is protective. But the other factors that really matter, particularly if you're someone like me who's a clinical geneticist, family history really counts. As does heritable genetic risk factors. And the reason I split them up is because sometimes people can carry hereditary risk factors that don't have a family history of ovarian cancer. So it's important that we don't discount the people that don't have a family history as not requiring genetic testing, because often they will. So we will still offer genetic testing to people even if they've never had a family member other than themselves affected. So this slide, many of you who've seen me speak before will have seen this slide, and it's beautiful. It's one I've nabbed from Genomics England, and this just demonstrates the complexity that is our genome. So I keep it very simple in my own head because it is a complex entity. So just think about your genomic information like being the instruction booklet that controls how your body grows and develops, basically. And genes are like words in that instruction manual. Okay. And there's little chemical building blocks that we can think about like being letters in these words. Genes basically, work to do, they work to create proteins, and it's proteins that do the different jobs in the body. And certain genes, certain proteins work to prevent cancer. And everything is hunky-dory unless you happen to have a spelling mistake in one of those words, in one of those genes. And that leads to a faulty protein that can't do the job that it's supposed to in the body. So when we're doing genetic testing, we're basically just doing a very sophisticated spell check, essentially, to make sure everything is as it should be. So this is where it starts to get very complicated, because we talk about the genetic basis of cancer, and all cancer contains genetic changes, but not all of those genetic changes are hereditary issues, because the cells can acquire things by chance themselves. So let's pretend for a second this is a normal cell in the ovary. That normal cell in the ovary divides to create two daughter cells that should be identical to the first cell. But you know yourself, copying over is not an error-free process. So you can remember, I don't know if any of you were bold in school, I certainly was. And, you've made write out lines and lines. I will never do this again. I promise to be quiet, whatever. Even if you're writing a sentence you're very familiar with, you're able to spell all the words, you'll still, make little errors. You'll still slip the pen every now and again. That happens in our cells all the time as well. So you get these little blips that happen in our cells during that copying over process. And we're very lucky because the body's very clever, and most of the time they're corrected and it's fine. But sometimes they're not. And if they're not corrected, then when that cell that contains this new error divides into two to form two daughter cells, they also contain the errors. And actually, they're becoming increasingly unstable because that error might be in a gene that's supposed to prevent all of this happening or correct it when it does happen. And what happens is they ultimately collect all of this damage. That makes the cell very abnormal, and ultimately they become cancerous. And what we are trying to do in the world of cancer treatment now is, if we can figure out what's that little blip that happened along the way to transform this cell from normal into a cancerous one, and do we have a drug that we can use to counteract that, right? So lots of genetic testing is happening in cancer at the minute. So we do a biopsy, we look at it under the microscope, but we also take a little sample that we can do molecular analysis on as well. And that's what we're looking for. We're looking for these culprits that have turned that cell from normal to abnormal. The difficulty, though, is when you're doing that type of testing on a cancer cell, yes, you're going to pick up the genetic changes that have happened by chance, but you also might pick up genetic changes that have been there even since the cell was normal. Because remember, if you carry a hereditary genetic risk factor, that'll be present in all of the cells of your body as well. So when I stick my needle into this cancer here and I pull out a load of cancer cells, yes, I'll pick up the genetic alterations that have happened by chance. I'll also pick up whatever was there in the background in terms of hereditary risk factors as well. So that's why oncologists sometimes are faced with this issue where they've done a tumor test looking for spontaneously acquired things, but they're coming back to the person they've done the test for and they're saying, we found this, we don't know if it's inherited or not. We need to figure this out. We need to get genetics involved. We need to do further testing, etc. So how do I figure out if I've identified a genetic alteration in a cancer cell? How do I know it's inherited? Well, we move to testing normal cells, right? We want to see if it's present in the normal cells in the body as well. And in practice, what we use most commonly is a blood sample. So, now we're talking about ovarian cancer today. The only scenario where this is not helpful is for people that have leukemias, because obviously the cancer is in their blood. But for people with ovarian cancer, you can use a blood sample. And if you find the genetic alteration in the blood cells as well as in the ovarian cells, you know that has to be a hereditary issue. And the term we use in genetics is that's present in the germ line, meaning that it's also present in the cells that make the egg cells. So their children are also at risk of inheriting this issue too. The other word you might see occasionally is constitutional, which sounds very fancy, but it means the same thing. It just means hereditary. The other scenario is when we identify a genetic alteration in the ovarian cancer cells, but when we test the blood sample, it's not there. And that means that this genetic blip is likely to have occurred in the cancer cell by chance, for whatever reason, as the cancer was developing. And those kind of genetic changes are not pass-onable, so you can't pass them on to your kids. And they are referred to as somatic variants. They're still very important to identify because it might mean changes to your treatment. But in terms of your kids and other members of the family being at risk, a somatic alteration isn't associated with heritable risk factors. Why am I talking about all of that? Because it matters when we're talking about ovarian cancer. So you may or may not know that when somebody is diagnosed with ovarian cancer, that's sort of a meaningless term. It just means there is a cancer in the ovary. But what I want to know, what any doctor treating you will want to know, is what subtype of ovarian cancer are we dealing with? And the way we characterize ovarian cancer is how it looks under the microscope. So you can broadly categorize it into two things called epithelial, which means within the cells of the ovary, or non-epithelial, which means it's cancer of the supporting structures, the supporting cells in the ovary. They're much rarer, and I'm going to talk about them at the webinar next week. For today, I'm going to focus in on epithelial ovarian cancer. And even within that epithelial ovarian cancer subgroup, you can divide that again into high-grade serous, low-grade serous, clear cell, and endometrioid. And those types, not only do they differ based on how they look under the microscope, they also differ in terms of what those genetic blips that are responsible for triggering this transformation from a normal cell into this particular cancer type. They differ, okay? Now, the ones that are highlighted there in yellow are ones that are much more likely to occur by chance in the cancer cells. So these are very unlikely to be heritable genetic risk factors. And that's why when somebody asks me, and we certainly, the Ovacom team will know that we get comments and queries about this all the time. People ask, I've got a low-grade serous cancer, what's the risk to my daughter? And I can respond and say, that's very unlikely to be related to a hereditary risk factor. And the reason I know that is because the genetic blips that happen in low-grade serous cancer are much more likely to be those that occur by chance rather than those that are hereditary events. On the next slide now, I'm going to show you the ones that we do kind of worry about. So the ones that I've highlighted in blue here, these can occur by chance. They can definitely still occur by chance in the cancer cell, but they can also occur as hereditary events. So if somebody says to me, oh, I've got a high-grade serous ovarian cancer rather than a low-grade, that's when I start to get a little bit twitched. And I'm like, actually, there is a decent chance that there is a hereditary risk factor at play here. And we do need to see you, and we do need to review your family history and think about genetic testing for hereditary risk factors. So that might, people sometimes worry about, being denied a genetic test. It's not that we're trying to be obstructive. It's that we want to make sure that we're offering genetic testing to the appropriate people where we're most likely to find a hereditary risk factor. We don't want to be causing huge anxiety and lots of worry in families where actually the likelihood of it being hereditary is extremely low. So for people with low-grade serous cancer, mucinous types of ovarian cancer, the likelihood of those being hereditary, very, very low. The only caveat to that is if there's a huge family history of ovarian cancer, in which case the first thing I would do is go to the pathologist and say, are you sure that's the subtype that we're dealing with? Because we may need to look at that again. Okay, so when we think about hereditary risk factors for ovarian cancer, we sort of divide them very crudely into 3 categories, and you can probably guess the categories. Well, they're there on the screen for you, but the categories are basically high risk, moderate risk, and low risk, and they're divided into those categories based on the lifetime risks associated with alterations in the different genes. Now, these are sort of artificial categories because the ranges overlap, as you'll see in a few minutes. But essentially, we consider anything that has a 10% or greater likelihood of causing ovarian cancer. They're considered high risk. Moderate risk are those where there's between 5 to 10% lifetime risk of ovarian cancer. And low risk is when you're kind of close to the population risk of 1 in 70. So that's less than a 5% lifetime risk of cancer. And we've identified different genetic alterations in each of those categories. At the minute, testing in the NHS focuses on those genes associated with high and moderate risk. There's lots of interest on the genetic alterations associated with low risk. The difficulty with these is low risk genetic risk factors for any type of cancer are extremely common. You know, I certainly have a few, if not loads of them. And each of them individually, big deal. You know, they might increase your risk by 0.5% or 1% over your lifetime. You're not going to lose any sleep over that. But if you have 50, 60, 70, 80 of these low risk factors, then actually the combined effect might start to push your risk up quite significantly. The reason we don't offer testing for those yet is because we haven't really cracked how you add those up. So, you know, the fact I have 60 low risk genetic risk factors for ovarian cancer doesn't automatically mean my risk is 60%. You know, it may still only be 11%. We just haven't figured out how to incorporate that information into a meaningful kind of number. So at the minute, that's being explored on a research basis. There are a few commercial companies that are offering what they call polygenic risk scores. That's the kind of name that they put on that combined risk. I take it with a pinch of salt because, you know, you could go to a couple of different commercial companies and order a polygenic risk score for ovarian cancer and get completely different answers. So I think until there's a bit of, you know, quality control kind of measures in place, I would hold fire doing that kind of testing. I think as long, you know, unless it's part of a robust research project, I would be very careful about over-interpreting those things. So you can see the genes that fall into the high risk category, BRCA1 and BRCA2. I'm going to sort of ignore them for the rest of the talk, and we're going to focus more on the genes in this category. So PALB2, RAD51C, RAD51D, the genes associated with Lynch cancer, and another gene that I've actually forgotten off that slide called BRIP1. So before I get into the nitty gritty, I just want to talk a little bit about how you manage ovarian cancer risk. So this is in the unaffected individual who knows they carry a genetic risk factor for ovarian cancer. The reason I'm talking about this first is just to set the scene as to how we've determined the guidelines for the different genetic alterations, okay? People will often ask about the smear test and whether that's any good in terms of identifying changes in the ovary. Effectively, no. And the reason for that is the smear test is looking for changes in the cervical cells. And actually nowadays, what it's checking for is actually the virus that's typically associated with cervical cancer rather than looking for abnormal cells. So the smear test, we still encourage everybody to do it because it's certainly an important test in terms of facilitating early detection of changes in the cervical cells, but it's not really worth diddly squat in terms of detecting ovarian cancer. So keep up with it if you have a cervix, but it's not going to change your risk of ovarian cancer. People always ask about scans, and sadly, it's sort of a heart-sinking situation because scans have not really been proven to be useful enough to detect ovarian cancer at an early enough stage to change outcomes massively. The reason for this, it may be plumb normal in early stages, and it's also really difficult to differentiate between benign and cancerous growth in the ovary. So we don't routinely recommend screening for ovarian cancer outside of research studies or very expert centres. There's also a lot of interest in blood tests, so a marker called CA125, and those of you that have had ovarian cancer may well be very familiar with this. So CA125 is a phenomenally helpful marker if you know somebody has ovarian cancer, because usually when a woman has particularly the high-grade serous ovarian cancer, the CA125 is up in the sky, and when you give chemo, you can see that the CA125 usually comes down really nicely if that woman is responding. The difficulty is not everybody has a high CA125, even if they have ovarian cancer. And also it can be increased for other reasons. So if you're somebody that has a genetic risk factor for ovarian cancer, has a blood test saying, oh, you've got a high CA125, that causes huge anxiety, massive anxiety, and that can't be underestimated, and it can lead to lots of over-investigation and sometimes unnecessary surgery. So we don't recommend that routinely either. So what do we recommend? So at the minute, the only proven way to minimize your risk of ovarian cancer is to have risk-reducing surgery. And as I mentioned at the start, most of the ovarian cancer, particularly the serous type, we believe actually starts in the fallopian tubes. So as part of your risk-reducing surgery, they need to remove your fallopian tubes and your ovaries. And that procedure is called a bilateral, which just means both sides, salpingo, which is the tubal bit, and oophorectomy. So bilateral salpingo oophorectomy, or you might hear it called BSO. So risk-reducing BSO. The operation is usually done by keyhole. It's usually a day case procedure, so you're home in your own bed that evening typically. The surgery tends not to involve removal of the womb. So removal of the womb, the technical term for that is hysterectomy. And people will always talk about, oh, my cousin had a hysterectomy because she's a carrier of whatever gene alteration. Actually, the operation that she probably had was probably a BSO, and her womb is probably still sitting there in her pelvis. And the reason they tend not to take out the womb at the time of this surgery, it's a much bigger operation to take out somebody's womb. And also the risk of cancer of the womb is not known to be significantly increased in many of these. Now, I will talk about Lynch syndrome later on, which is a different kettle of fish, and those women do need their wombs out. But for most of the other genes, we usually leave the womb in where it is. The BSO operation dramatically reduces your risk of developing cancer of the ovaries or fallopian tubes. It can't eliminate it completely because that lining on the inside of the abdomen that I mentioned earlier on, the peritoneum, those cells are really closely related to the cells in the ovary and the fallopian tubes. And you can't remove the peritoneum. It's just too morbid an operation. It's too high risk to do that. So there is a tiny residual risk of developing cancer in the peritoneum after this surgery. That risk is highest in those women where you find precancerous changes in the fallopian tubes. And actually, if you don't find those precancerous changes, the risk of that is pretty low. But that's why we're very, very pedantic about how carefully we examine the fallopian tubes after somebody has had a risk-reducing surgery. So we do that really, really carefully. And that's why we're so careful about where we refer women for that surgery, because the surgery itself is pretty straightforward. Actually, any standard gynecologist can do that surgery. Any general surgeon could do that surgery. But we need specialist pathologists that know what they're looking for to examine the fallopian tubes carefully. So that's the huge advantage to that surgery, but there are negatives as well. The big negative is if you're having this surgery before your menopause, you're immediately flung into the menopause. And surgical menopause is literally overnight. There isn't any kind of nice lead in. It's you go to sleep and you wake up with hot flushes. So that's not necessarily always very pleasant. And early menopause is associated with negative side effects. So we know that people who have early menopause have higher risk of heart disease. They have higher risk of osteoporosis and reduced bone density. They have higher risk of cognitive issues and dementia. So to try and counteract that, we tend not to do the surgery very early. So the absolute earliest we would ever consider this is 35. And that's really only in women that have an extraordinarily high risk of early onset ovarian cancer. In most cases, we tend to try and push it out closer to 40. And for some of these rarer things, even after the menopause. And I'll talk about that later on. The other consideration, as well as an early menopause, is obviously fertility considerations, because nowadays a lot of people haven't even started having kids before they're 35 or even 40. So we need to consider that when we're thinking about the timing of this kind of surgery. Okay, that's the preamble, and now we're going to get into the meat of why we're here today. So I do need to just mention BRCA1 and BRCA2, BRCA1 and BRCA2, just to set the scene. So BRCA1 and BRCA2 alterations, they're actually not that rare. So if I walk out into the car park, the likelihood of finding somebody that carries a BRCA1 alteration, about 1 in 380. And for somebody that carries a BRCA2 alteration, about 1 to 277-ish, right? And if you're somebody that has an Ashkenazi Jewish ancestry, there's a 1 in 40 chance you carry an alteration in one of these genes. And people who carry alterations in these genes, you can see from the slides there, they have really high risks of breast cancer, really high risks of ovarian cancer, also have other cancer risks, including pancreatic, and in male carriers, prostate cancer. And there's increasing evidence for an association with stomach cancer as well. But certainly for today's talk, we're going to focus on the ovarian risk. Definitely high risk. I don't think anyone would question that. And they certainly need all the intervention that we've just mentioned. Two other genes that are very strongly linked with ovarian cancer as well that are getting less attention are RAD51C and RAD51D. And the reason they get less attention is they're rarer. So these are, alterations in these genes are much rarer than in BRCA1 or BRCA2. So you can see there, if I go into the car park, I'll need to test 880 people to find an alteration in RAD51C, and I need to test nearly 2,000 people to find an alteration in RAD51D. So these are not common issues. There are cancer risks associated with these. So there is a risk of breast cancer in carriers of alterations in these genes. They're more modest than in the BRCA1 and BRCA2 carriers, but still enough to warrant enhanced screening. And the risk of ovarian cancer, you can see some women are on the moderate end of the spectrum at kind of 6 to 7%, but there are some women that will have over 20% risk of developing ovarian cancer. And sorry, you can ignore, I should have changed these slides because I copied and pasted from the BRCA slides, but ignore the pancreatic, prostate and stomach risks. They're copied over from the last slide, so you can pretend they're not there. The reason that the risks that I've quoted there are so broad is the risks associated with alterations in RAD51D and RAD51C are really strongly altered, or they're really strongly modified by your family history. So if I carry a RAD51C alteration and I don't have a family history of ovarian cancer, my risk is probably about 11%, which is still tipping me up into the high risk category, but there's still an 89% chance I'll never get ovarian cancer. Whereas if I have two first degree family members, so a mother, a sister, a child, affected with ovarian cancer, then actually my risk goes up to 30%. I would not sleep comfortably at night at that level of risk. And similarly, RAD51D, the same kind of impact. And you also see the same effect if somebody has a family history of breast cancer. If I have two first degree relatives affected with breast cancer, my risk all of a sudden is not so modest. It actually is tipped up into the level at which you would even consider risk reducing breast surgery, and certainly enhanced surveillance. Now, the thing about RAD51C and RAD51D gene alterations is the risk really doesn't start to creep up until late 40s and even after 50. So in these carriers, we don't really recommend doing early risk reducing BSO. We would tend to wait until later in the 40s to do that kind of operation for carriers of alterations in these two genes, depending on the family history. If you turn around and say to me, well, my sister was only 38, that's different. Okay. PALB2 is another gene that we think about as well. This gene is more often implicated in the breast cancer side of things, but there is an ovarian cancer risk as well. So again, this is rarer than BRCA1 or BRCA2. So about 1 in 770 people in the general population carry an alteration in this gene. There is a high risk of breast cancer, and there is this kind of low to moderate risk of ovarian cancer. Okay, there are potentially other risks as well, including of the pancreas. Now, PALB2 is a really tricky gene because the level at which we would recommend risk reducing ovarian surgery, it used to be 10%. Okay, but we have come down now and we will consider it at 5%. But if you're somebody sitting with a risk of 2%, that's basically the same as the general population. And we don't go out, we're not going around whipping out everybody's ovaries. So we need to be very considerate in who we offer this surgery to, because surgery is not without its risks. There's a general anesthetic. you're having instruments poked into your abdomen. You know, you need to be sensible about who you offer this operation to. So how do I figure out what the risks are? So if I had no family history of ovarian cancer at all, my risk is about 5%, but that range between 2 and 10. If my mother was affected in her 30s, I'm getting up close to the high level of risk. If I had 2 first-degree relatives, I'm in the high risk category, et cetera, et cetera. And it depends on the age at which they were diagnosed. But there's a lot of other factors to consider, because you can still see there's wide ranges there. Like, you know, this person that had a mother and a sister affected at 50, the range is anywhere from 8 to 28%. Like, that's massive. That's the difference between offering somebody risk-reducing surgery and potentially not. So how do we figure it out? So, oh yeah, sorry. The other thing to mention is, again, the risk really doesn't start to increase until after 50. So if we do consider risk-reducing surgery in carriers of PALB2, we really don't recommend it until after the age of 50, because the risk before that is so low. So in these women, you can wait until they're kind of at the age at which they'd have their natural menopause. So that's the silver lining, if there is any, to this particular gene. Oh yeah, sorry. I was going to talk about risk estimation. I'll do that after this gene. So I see in the chat, actually, someone's asked about BRIP1. So you were reading my mind. BRIP1 alterations are probably a bit more common than some of the other ones we've mentioned here. So about 1 in 400 people in the general population have an alteration in BRIP1. When this gene was discovered originally, we actually thought it was very closely linked with breast cancer. That has since not come out to be the case. So we actually don't consider it a breast cancer risk gene anymore. But we do know it is linked with ovarian cancer risk, and the risk is in the order of 4 to 11%. So again, it's one of these kind of genes where some women will fall into the low risk category, but others will fall into the moderate risk category, where you will start to think about risk reducing surgery as well. We actually don't think it's very strongly implicated in other cancer risks. So it seems to be a very ovarian cancer specific gene, but you know, there's lots of research still ongoing, because it's not a gene we've been testing for very frequently, so we're still learning about it. Now, the good news, in inverted comma, about BRIP1 is it tends to be associated with later onset of disease. So the average age is about 68. What that means, and the reason I say that's good news in a way, is the unaffected female relatives of somebody that has a BRIP1 alteration, if they are found to carry the same alteration, they're not likely to need an early BSO. They're likely to need risk-reducing surgery at some point, but it can be deferred until closer to the age of menopause. Again, unless there's a family history of very early onset disease. Okay, this is what I wanted to get into now. So, you know, I've given you really wide ranges. Like, that's not that helpful when you're trying to make a decision for yourself. And, you know, if you were to come to see me in clinic, I want to give you a more individualized risk assessment that, you know, it needs to be a bit more tailored to your scenario. So how do we do that? Well, we're really lucky. This is a screenshot from a program some of you may or may not have had exposure to with your doctors previously. It's a thing called CanRisk, which is developed by our colleagues in Cambridge. It's a fantastic tool. You can see it's got loads of endorsements. It's used by us in the Cancer Genetics Group. It's used by the National Institute for Health and Care Excellence. It's used in the European networks, in the American guidelines. It's great, okay? What it does is it takes into consideration a load of your details. So this is me. I've aged a little bit. I'm 67 now. But you can see you plug in your things about your height and your weight. You plug in things like how often you drink and how much you drink and what type of drink you have. You plug in things about your reproductive risk factors. So what age you were when you had your first period. Did you ever take the pill? How long were you on the pill for? Have you ever had HRT? Children, so do you have kids? When were they born? What was, you know, the important thing here is what age you were when you had your first one and how many of them you've had. Have you ever had any breast screening? Have you ever been diagnosed with anything like endometriosis? Have you had your tubes tied, which is also protective? Have you had your ovaries out? Because obviously having your ovaries out is protective against ovarian cancer as well. You plug all that in, you plug your family history in, you plug in your information about your genetic test. So in this scenario, I've decided I carry a PALB2 alteration. And actually, if you look at my family history, my sister was diagnosed with ovarian cancer at the age of 68, and she had the big ovarian cancer gene test that's available on the NHS and was found to carry this PALB2 alteration, which I've also inherited. So I want to know what my risk of ovarian cancer is. Am I one of the people that has a 2% risk, or am I one of the people that has a 10% risk? And what should I do with my ovaries? So you plug in all of that information, and CanRisk spits out this lifetime estimate of the woman's risk of developing ovarian cancer over her lifetime. And you can see it gives you an estimate over the next 5 years, the next 10 years, and before the age of 80. And you can see my risk before the age of 80, 2.5%. So actually I'm on the lower end of the spectrum. And the reason for that is I've had a couple of protective things that I've put into that model. So I've been on the pill for a few years, I've had a few kids, I don't drink very much, I'm normal weight. You know, all of those factors are considered in terms of how your risk has been modified. And obviously they consider your family history and the age at which the relative was diagnosed, etc., etc. It plugs out these beautiful risk estimates. So you can see your risk over the next few years and what that risk is compared to the population. So certainly, you know, I carry a genetic risk factor for ovarian cancer. My risk is increased compared to the average woman, but it's not at the level at which I would start putting myself through general anesthetic and risk reducing surgery. Again, it just gives you this lovely graph, which puts, you know, I'm quite a visual person, so I like seeing this. You know, that's, you know, if you look, it's pretty close to the population level when you look at it like that. Okay, I'm going to move briefly now to talk about Lynch syndrome, which is a condition that is not rare, you know, but I've included it in this rarer causes of ovarian cancer because it's often overlooked as a cause of ovarian cancer. And the reason for that is we were very bad at the way we've branded it. So when it was named originally, it was called, very catchy title, Hereditary Non-Polyposis Colorectal Cancer Syndrome. And it's misleading for a couple of reasons. So first of all, you do sometimes get polyps in the bowel, so the non-polyposis bit is wrong. It's also not just colorectal cancer, so it's not just bowel cancer that happens as part of this condition. You can get cancers, yes, cancers of the bowel are the most common, but you also get cancer of the womb in affected women. You get cancers of the pancreas, cancers of the stomach, cancers of the kidney. You can get a heap, all kinds of everything, really. And about 1 in 279 people in the population have this condition. It is not rare, but it is woefully under-recognized. It is really not picked up often enough. So obviously for today, we're going to focus on the ovarian side of things. The ovarian risk depends on which of the genes is involved. So there's actually 5 genes, sorry, involved in Lynch syndrome. The names of the genes, just for interest, are MLH1, MSH2, a gene called EpCAM that works very closely with MSH2. So we sort of lump those two in the same category, which is why I said 4 at the beginning rather than 5. Another gene called MSH6 and another gene called PMS2. And 3/4, if you count EpCAM, of those genes are associated with ovarian cancer risk. PMS2 is not known to be associated with ovarian cancer risk, but it is associated with Lynch syndrome, so we do still talk about it. You can see the risks are wildly variable depending on the gene and depending on the alteration and depending on the family history and all of the other modifiers we talked about. So the risk can be as low as 4% right up to 39%. You know, there's huge variability, huge variability there. So what kind of subtypes do you get? So the serous subtypes are less commonly implicated in Lynch syndrome. So you tend to get subtypes like the endometrioid type or the clear cell type. Mucinous subtypes have rarely been reported, but actually what's not very clear is if the mucinous cancers in those women was actually due to the Lynch syndrome or if they were just happened to be one in the 279 people that have Lynch syndrome and happened to get a mucinous cancer. But certainly we would still consider testing for this condition in somebody affected with a high-grade cancer, particularly if they're affected at a young age. The average age at which ovarian cancer is diagnosed in people with Lynch syndrome is younger than in the general population, so about 48 at the time of their diagnosis. There is some good news here. So there tends to be this tendency to diagnosis at an earlier stage than the general population. And because of that, the outcome is better. And actually the outcome is better even when you're staged matched with other women who have the same type of cancer that don't have Lynch syndrome. So there is some good news. Risk reducing surgery in people with Lynch syndrome is slightly different than what I've mentioned earlier on. So Because of the very high risk of womb cancer in these women, they do need to have a hysterectomy to remove their womb, and that's typically recommended around the age of 40. So what we don't want to do is put people through two different risk-reducing procedures. So we tend to recommend that their ovaries are taken out at the time of their hysterectomy as well. So they have this convoluted term, a bilateral salpingo oophorectomy with a hysterectomy. The only women where we don't typically recommend that is in women who have Lynch syndrome due to PMS2 gene alterations, because as I mentioned, PMS2 is not typically associated with ovarian cancer risk. Now, you may end up doing it for other reasons. So if they have, endometriosis involving the ovary, you may take it out. There's a move now with the Royal College of Obstetricians and Gynecologists. There's a move actually to taking out the tubes in anybody having a hysterectomy, because if you remove the tubes, you probably reduce the risk very significantly anyway, because we think most of the cancer starts in the tubes. But you don't necessarily put that person into menopause because you leave their ovaries where they are. So they may do that. They may do a hysterectomy and an opportunistic salpingectomy in those women. But you may consider taking everything out if a woman has, definitely if they have a positive family history, so if they've somebody belonging to them that's had ovarian cancer, or if they're postmenopausal and the risk associated with it is low. So that's kind of a case-by-case basis that you discuss that. Okay, so now I just want to come on to what's available in the NHS, because there's a lot of confusion about this, not just from the patients, but from the clinicians as well, because this is a really rapidly moving target, if you like. So the guidelines for testing in people with ovarian cancer was last updated in 2022. Okay. And what the updates involved was, extending the testing to more people, but also extending testing to more genes. So for a long time, we only tested BRCA1 and BRCA2 because they're more common and because they are higher risk. But now we test for BRCA1, BRCA2, PALB2, RAD51C, RAD51D, BRIP1, MLH1, MSH2, and MSH6. So the genes that I've just talked about today. And the people that are eligible for that testing are the people with the subtypes of ovarian cancer that are more likely to be linked to hereditary risk factors. So the slide I showed at the very outset of this talk. So people that have high-grade cancers, so high-grade serous, endometrioid, or clear cell types. If you have any of those type, doesn't matter what age you are, doesn't matter about your family history, you're entitled to a test for hereditary risk factors if you have any of those type of cancers. And certainly if you have a family history of, any of the associated cancers, so breast, prostate, pancreatic, bowel cancer, womb cancer, we would want to see you in clinic as well to think about genetic testing. So why is this all important? So we've talked about risk management. The other reason that it might be, just to before I get into this, the risks to the children of an affected individual. So if you carry an inherited risk factor for ovarian cancer, any of your children, male or female, because remember, men can carry these as well as women, even if they don't have ovaries, they have a 50-50, 1 in 2 chance of inheriting the same genetic alteration. So if you're somebody that hasn't yet had children, this may influence the decisions that you make about your family planning. So obviously this is for people who haven't been affected by ovarian cancer and still potentially have the opportunity to have children, biological. Oh, well, you may have that even after you've had ovarian cancer if you've had fertility preservation or what have you. Some people, I get very sad actually when people make this decision, but some people, if they know they carry a genetic risk factor for cancer, they just decide not to have their own biological children. They don't want to run the risk. Some people will still have children, but not their biological children. They'll adopt, or they'll, have embryo donation, or they'll have sperm or egg donation, depending on which parent carries the genetic risk factor. Some people have testing before pregnancy where they do IVF and then testing of the embryos for the genetic alteration. Some people have testing during pregnancy with termination of the affected embryos. It tends not to be a hugely popular choice if it's something that's associated with adult onset conditions. But, there's a whole rake of options available to people when they're planning their family. The other thing that I always talk about it in this kind of forum, because I think it's important to realize that it's very normal to have an emotional reaction to being told that you've carried, or that you do carry, a genetic risk factor for cancer. it's more than a blood test. You know, I think people really minimize it. You know, when clinicians are offering, they're like, oh, it's a simple blood test. And you're like, it's a blood test that can be life altering. You know, so the psychological impact is fairly significant. And that's why organizations like Overcome are so important. You know, that just having that support network is invaluable. You know, obviously your medical team can provide you with information and support. I think where people feel most lost is after they've had their cancer treatment and they're kind of discharged into the sunset. You're kind of, you know, there can be a period where you don't feel you've got that scaffold in the background. There's loads of cancer support groups as well, and there's various websites. The Royal Marsden has lots of patient information on our patient information library that I hope people find useful as well. So, summary of all that, because I'm very conscious, I just want to leave a bit of time to deal with the questions. One size fits all is not appropriate. You know, these risks they need to be individualized to the person, considering all of the other factors, not just their genetic makeup. Genetic testing should be offered to everybody with a high-grade epithelial ovarian cancer. Cancer risks are influenced by other factors other than hereditary risk factors that I've talked about. Risk reducing decisions need to be made bearing in mind people's age, their gender. I haven't even gone into the transgender issue. The people that are transgender need special consideration, and we might talk about that in a separate webinar at some stage. We need to consider family history, personal circumstances, things like family planning considerations. All of that need to be considered. And the other thing that needs to be considered is your cancer treatment. So, you know, people who have genetic risk factors for cancer, if they haven't had ovarian cancer yet, they may have had other cancers. So they may have had breast cancer, they may have had pancreatic cancer. That will influence what you do in terms of your risk management as well. And obviously family planning considerations depend on the person's age, the relationship status, whether they've had cancer, and their own personal decisions. So remember, you know, you're a part of all of these decisions. This isn't a paternalistic pathway at all. You're very central to all of these decisions. So I think that's everything I have to say. Stop here.
Fabulous. Thank you so much, Dr. McVeigh, for a really, really comprehensive and really informative and clear session delivered there on what is clearly a very, very complex topic. So we're really, really grateful for your time today. And we have got a couple of minutes for some questions. So as discussed at the start, any questions which kind of relate to your personal situation, we won't put to Dr. McVeigh today. We're here to take questions that are a bit more general. So we've had a few of those come through. So somebody has asked, what genetic tests are available to test for mutations which can be targeted by current drugs, and how do you get them?
Yeah, so there's a certain amount on offer in the NHS. So for people that have serous ovarian cancer, there's definitely a lot of tests that they can have. So there is, you know, the tests that are available will test for spontaneously occurring changes in BRCA1 and BRCA2 that I've ignored for today, but they are still very relevant because there is a targetable, you know, so these drugs called PARP inhibitors work against, they're particularly effective against BRCA-related cancer. So that's available to everybody with the serous ovarian cancer. There's also another test called homologous recombination repair deficiency testing, which sounds very complicated, but that's just the DNA repair pathway where a lot of these genes work. So PALB2, RAD51D, RAD51C, BRIP1, BRCA1 and BRCA2, they all work in that repair pathway. So anybody with the serous ovarian cancer, you're entitled, as part of the NHS service, you're entitled to have HRD testing. And that may or may not determine whether you're eligible for certain targeted treatments as well. So there's lots happening in the NHS. There's a view actually to offering far broader testing for patients with ovarian cancer that was planned for Q4 2022, and here we are Q4 2023. So we're hoping that there will be much more extensive testing to pick up more and more targetable things, but it's really driven by the availability of the drug. So, you know, if there is a drug for which, you know, we can target, that's what will drive introduction of the genetic test, because the way we work in the NHS is we're only going to do a test if it's useful. So doing a test to find a genetic alteration for which there's no drug is not that helpful, unless it clarifies diagnosis. So the other scenario where we offer genetic testing on the tumour is if we can't figure out what subtype it is. So like I put up that slide earlier on, I can predict what the tumor should look like under the microscope based on the molecular pattern. So if the pathologist can't figure it out, they'll often ask us to do genetic testing to try and see what we think it is. And we'll come back and go, I don't think this is whatever, I think it might be whatever. And actually then they'll have a second look and go, yeah, I think you're right. You know, so it's useful for refining the diagnosis as well as for targeting the treatment. You know, but your oncologist will definitely guide you because it very much depends on the subtype of cancer and what treatments they think might be useful.
Absolutely. Thank you for that. A question as well, how do you find out about trials that may be targeting certain mutations?
So your oncologist is definitely the best protocol for that, because what's very difficult is when you look for these trials on the internet and things, it's not necessarily the most up to date. They won't necessarily tell you what slots are available and what, you know, what trials, etc. So your oncologist is definitely best placed to tell you about what clinical trials are available. If they don't know what's available in their institution, they'll probably be able to refer you to, you know, the Marsden, where we have lots of trials, or, you know, to your local trials unit, or there's very early stage trials units as well, so the phase 0, you know, phase 1, phase 0 trials units as well. But your oncologist, you know, gynae oncologists are excellent for keeping up to date with clinical trials, so they're the first port of call for sure.
Thank you. Someone is asking about the CAN risk tool, which I've certainly made a note of as well. So they are asking, is this available to individuals to access or via professionals?
So it like anyone can sign up to use it. The only thing I would say is that it's probably best done in the company of a genetic health professional, or, you know, a healthcare professional, only because some of the terminology around it and some of trying to unpick the kind of intricacies of the risk assessments are very challenging. But you can go in and play around with it, because actually the way the questions are posed, because I was one of the first people, they did this kind of user testing and somebody sat down beside me and watched me use it to see how user friendly, and I'm a complete technophobe, so if I can use it, anyone can use it. But the first question is, what age are you? Or, you know, what's your birthday? And I answered it as me, Terry. I was like, yeah, 25th of July. You know? And they were like, no, that's the patient. But they're kind of phrased as if you're the patient filling it in. And it's like, have you ever had your ovaries out? Have you ever had whatever? So it is designed to be pretty user friendly, but I think I would be very careful about interpreting the results without having a healthcare professional have a look at it. And to be honest, any healthcare professional is going to want to run it themselves, you know, to make sure that it's all been done properly. But yeah, have a squint at it. Like, it's really interesting to just look at the kind of different permutations and combinations, and the graphics are beautiful. I think I definitely am really visual, so I like it when you can get the graph to go, actually, I thought I was really high risk and that table freaked me out, but when I see the line in the general population, I'm pretty close to it. I think that's really helpful. Or otherwise, if you are kind of high, you know, high in the sky, that's can sometimes be impactful as well, you know.
Absolutely. Thank you for that. Someone has asked, can we go on to developing ovarian-related cancer in that general area, even if we have had a full hysterectomy? They've mentioned that they have the RAD51D.
Yeah, so the RAD51D, so this is where you need to start getting very pedantic about the terminology. So hysterectomy refers to removal of the womb, okay? But having a whole hysterectomy, it's not always clear if they've actually taken out the ovaries and the tubes. Okay, so the first thing to ask that person is, when you say full hysterectomy, do you mean your tubes and ovaries are gone as well? Okay, and I presume because they've got RAD51D, I presume actually that's what they, but you can't presume anything in genetics. That's why I annoy everybody by getting reports on everything. I just want to see it in black and white what has been removed. So that's the first thing to clarify. Even if your ovaries and your fallopian tubes have been removed, there's a lining on the inside of the abdomen that I mentioned called the peritoneum, and the peritoneum can't be removed at the time of surgery. So there's always a small residual risk that there will develop cancer in the peritoneum. That risk is very low, particularly if there haven't been any precancerous cells identified in the fallopian tube. But the risk is not zero. So we do still recommend that women practice symptom awareness after they've had that surgery. So, you know, I wouldn't ignore bloating that's going on for weeks. I wouldn't ignore, it sounds really cheesy, but you know your own body, and if there's anything wrong for, you know, I usually say if it's something persistent for 2 or more weeks, that's when I would get advice.
Absolutely. Okay, if we finish off with a more sort of general question. So, what other lifestyle factors can one focus on to prevent the genotype becoming their phenotype, in addition to maintaining low to normal BMI, low to no alcohol consumption?
Very good. And the advice, sadly, is very boring. So, like smoking has not been particularly linked with ovarian cancer, but I always tell people to stop smoking because a lot of the genetic risk factors associated with ovarian cancer are also linked with pancreatic cancer, and smoking is very strongly linked with pancreatic cancer. So if you don't smoke, don't start. And if you do smoke, give it up. Alcohol, definitely, yeah, moderating your alcohol intake is a very sensible one. People always ask about these kind of fad diets, like, the low sugar, low carb, ketogenic. I think there's a lot of people making a lot of money out of selling books to people about this kind of stuff. And actually, the evidence for those kind of diets is not massively strong. I think keeping your sugar intake, on the low side is sensible advice, but particularly if you're going through cancer, denying yourself a biscuit is pretty mean if you're in the middle of chemotherapy. And equally, if you're someone at risk of cancer, you don't want it to subsume your whole life. It's all about balance, I think. So very boring advice, healthy, a good fruit and veg, and it doesn't need to be organic, as long as it's plenty of fruit and veg. The darker the better. So the dark green, dark blue, they contain loads of cancer fighting bad boys, the antioxidants that are really powerful for your health. But I get a bit stressed when people come in spending loads of money buying like really fancy organic, low sugar, low whatever, and actually all they need to do is just moderate their intake a little bit. So I don't get too excited, but I think it's great. Sometimes it's a real motivator. If you're told you carry a genetic risk factor for cancer, it can be a real motivator to actually improve a lot of your lifestyle, and that's beneficial for your overall health as well.
Absolutely. Yeah, really good advice to finish on. Well, thank you so much, Dr. McVeigh, again, for your time today and for taking the time to answer those questions. I am aware we've had some questions that have come in that haven't been answered. Obviously, we don't want to run the session over, but I think our advice would be, do approach your own team if you've got a particularly, a question that's bugging you relating to your own situation in terms of what we've discussed today. And they may well be able to refer you to a specialist. Would that be right, Dr. McVeigh? That would.
Exactly. Yeah, no, your medical team. And I think what I would encourage you as well is if you haven't been linked in with the geneticist, because obviously oncologists are doing a lot of this genetic testing themselves now. If you have any questions that you want a bit of clarity about, particularly around risk reducing surgery and when not to do it, ask for a referral to a genetic center. I think there is great value in talking to genetic counselors about all of this as well.
Absolutely. All right then, well, we will end today's session there. So thanks again, everybody, for coming. Thank you, Dr. McVeigh.